السلام عليكم. بداية أتوجه بخالص الشكر والتقدير للأستاذ الدكتور أحمد مدراتي، مدير ومؤسس مجموعة Excellence in Endodontics، لنشره العلم بحب وشغف حتى أصبح مثالا يحتذى في عالم وسائل التواصل الاجتماعي. Hello everybody. First, let me thank my mentor and role model, Professor Ahmed Madarati, for spreading the love and passion of endodontics. Friends and colleagues, I welcome you in the first Syrian Excellence in Endodontics online conference, and I am honored to be among such a great group of Syrian endodontists that I hope you really benefit from their lectures as they come out of great experience and up-to-date knowledge. I am Dr. Loay AlDehni, and this is my humble biography, and we are here today to talk about breaking the ice of complex anatomies, and we have chosen Radix and Entomolaris as an example. As we all know, the success rate of endodontic treatments depends a lot on the practitioner's experience and knowledge. The ultimate goal of root canal treatment is to isolate the supporting tissues of the teeth away from the oral cavity to eliminate the germs invasion possibility. This goal seems to be simple, but it needs a lot of complicated gadgets and procedures as the complexity arises from the details. By understanding the root canal treatment steps, we can mainly classify difficulties into two categories. The first one is tooth-related and the second one is procedural errors-related. Mandibular first molars are the permanent teeth which erupt first in mouth, and in parallel with their period of staying in mouth, they are the permanent teeth which are most influenced by cavities and most often requires endodontic treatments. So, its morphology has received a great deal of attention. No matter how many root canal treatments we did in our practice, each tooth is still a special case that we need to deal with. We are faced by different anatomies, so we need to be ready with wide concepts for proper treatments. Usually, the first lower molar has two roots, but occasionally three roots, and each root contains two or three canals. The mesial root canals are the mesiobuccal and the mesiolingual canals, but a middle mesial canal sometimes is present in the developmental groove between the other mesial canals. This canal may join the mesiobuccal or the mesiolingual canal, and in some cases it may be an independent canal with a separate apex. The distal root might be only one wide oval canal buccolingually, or it might be with two canals, one diverging toward the buccal and the other toward the lingual. Also, there might be a middle canal but rarely separated from the other distal canals. A variation in root morphology is the presence of an extradistolingual root, which is called the Radix entomolaris, a supernumerary root located in the mandibular molars. We had to go through this anatomy introduction because a practitioner should always be prepared for the variation in anatomy, like an extra canal or root or even C-shaped canals. A missed canal could lead to persistent apical lesion and disturbance for the patient and might even lead to tooth loss. In other words, missed anatomy means poor prognosis for the endodontic treatment. Radix entomolaris is generally a shorter and more curved root than the other molar roots. It could be separated or fused to the distal root. The prevalence of the Radix entomolaris in the literature ranges between 0.6 and 30% of the population. This is due to ethnic variation, as it appears mostly in the Mongolian population east of Asia, like China, Taiwan, Mongolia as an example, and the least in the Caucasian race. So, what might be rare in some population could be regular in others. This idea is especially important in multi-races communities. Now, we have an understanding of the issue we are dealing with. Every time we are treating molars, we are faced we are faced by different anatomies, so we have to search for the extra anatomy in order to achieve our own excellence in endodontics. But for that, we need some stable and hard principles and concepts. I believe any tips and tricks about dentistry in general and especially endodontics should start with magnification and illumination. And in order to make it a practical tip, not all about expensive tools that many dentists are not able to purchase, we can modify this tip from magnification necessity into seeing necessity. The more we see, the better we treat. We had a say among first generation dentists, and it is charming. The say is, eyes of the dentists are in the tips of their fingers. But a long time ago this say became not valid. So let's return the dentist's eye to his face, because the more we see, the better we treat. Dental microscopes have led a revolution in dentistry. We are seeing more extra canals everywhere on the social media. Many teeth that were doomed hopeless became full of hope thanks to the microscopes, which help increasing the ability to remove broken files, returning to the main course of the canal, or bypassing a ledge, or even sealing difficult perforations and dealing with complex anatomies. Also, the use of magnification as a simple dental loops helped us improving our posture while practicing. It minimizes the need to lean and tilt to see the lingual aspects or the occlusal aspects of the teeth, which means a lot less back pain and neck pain and less eye strain, and lead to less stressed practicing and more expected results. Also, it can prolong dentists' working hours. So, purchasing a magnification tool, whether it is an up-to-date microscope or a simple dental loop, is always good investment in the dental practice. Many dentists fail to continue the use of the loops because they don't give themselves enough time to become used to it, as it shows more details and needs a little time to practice, or just because they use the dental unit light only. In fact, the more we use magnification, the more we need illumination. So when using dental loops, one can use simple surgical headlight, as it may increase light level up to 4 times that of traditional dental operatory light. So in brief, in order to become excellent in endodontics, magnification is essential. Now, a study by Dr. Duman and his associates showed that 23% of lower molars with Radix Entomolaris had an extra tubercle. For this reason, it is important that in the presence of an extra tubercle in mandibular first molars, extra root presence be assessed by clinicians. Some tips never gets old. We have to carefully analyze the diagnostic X-ray and take it with more than one angle, remembering the slope rule, SLOP. As we take a shifted X-ray, the lingual object will be shifted in the same direction, but the buccal object will go in the opposite direction. Although this is a great tool, it may fail. It may fail to detect the Radix Entomolaris because sometimes this extra root is fused to the distal root, so it does not appear as an independent object, as in this case we are seeing now. After finishing with the shifted X-ray, we have noticed the presence of an extra root that wasn't appearing in the diagnostic X-ray. Now, we have a lower first molar that needs a root canal treatment, and we are going to drill for the access cavity preparation. A lot of concepts come to our mind in the access cavity design. Should it be traditional, conservative, or ninja access? The mutual objectives of this phase between all of these concepts is to remove all the caries, conserve as much sound tooth structure as possible, and remove all coronal pulp tissues and locate all the orifices of the canals. When we have a Radix Entomolaris, we will see that its orifice is located lingually at the dental aspects. In terms of the buccolingual orientation of the Radix Entomolaris, Dr. Ribeiro and Consolaro have made us a classification. This classification is type 1 refers to a straight root and root canal. Type 2 refers to an initially curved entrance and the continuation as a straight root or root canal. Type 3 refers to an initial curve in the coronal third of the root canal and a second buccally oriented curve starting from the middle to the apical third. According to this classification, we should expect a curve right from the orifice in the cervical third of the canal. When we are inserting our file, expecting the curve in the coronal third of the root, we have a famous tip here. The tip is to always pre-bend the tip of the file, the 2 mm tip of the file slightly before inserting it into any canal. And here we can see different types of pre-bending. After pre-bending the 2 mm tip of the file, we start inserting it into the Entomolaris, and we start with a wind-watching movement and without much pressure. The insertion is only to assess the volume and curvature degree of the canal. If the curvature in the coronal third of the canal is sharp and short, most authors advise to manually create a glide path. And another tip here in achieving the glide path is to start with a watch-winding movement until we pass the curvature, and after that start a filing motion to ensure it has been glided properly before starting preparation with rotary files. This step is so important because of the possibility to make a ledge at the coronal third, and we have to understand that Radix Entomolaris is a short, thin walls root. So an extra attention should be paid to not create a ledge or strip perforation. A small tapered files should be used, like file number 25 tapered 4%. As a final file, in most cases, it is enough. This advice is originally driven from the relatively new concept that we enlarge canals only to allow irrigants to reach and disinfect the complex anatomy of the canal. And in this size, with the activation of irrigation, many studies assures that effectiveness of this technique, as it allows relatively large amounts of irrigants to be in the canal because of the taper of the file, which prepared the canal into the form of a funnel, which also helps in the warm vertical compaction, as it allows relatively large pluggers to reach the middle third of the canal. Although other studies insist on the necessity to enlarge the apical region to a larger diameter in order to make sure no pulpal tissues is left behind and to make sure the apical third is properly disinfected. And in fact, there is no conclusive and evidence-based method. Each method of these has its limitation and the probability to succeed. But anyway, the first method has far more prevalence, as most endodontists use it and most companies design their files by it. Now, let us now discuss some clinical cases. The first case here is to a mid-30s female with symptoms on the right lower molars. After clinical and radiographic examination, it was diagnosed with acute apical periodontitis. Analyzing the X-ray image, something fishy was found and Radix Entomolaris was suspected. The crowns were removed and amalgam restorations also removed. By inspecting the access cavity, there was still a roof chamber not removed. After removing it, the floor of the chamber was cleaned with ultrasonics and an orifice was detected in the distolingual aspect of the floor. As earlier mentioned, a K-file number 10 was pre-curved and with watch-winding motion, the file was inserted beyond the coronal third curvature into the middle third. Then we changed the movement into filing motion to ensure the glide path. And then rotary files took care of the mechanical phase of the preparation. Impro files were used till the file number 25 taper 4%, and the rest of the canals was prepared to the same size. Irrigation protocol, my irrigation protocol, and I always use it, is sodium hypochlorite 5%, then serum, then ADTA, then serum, then hypochlorite again, then serum, then chlorhexidine as a closure. After that, all the canals were obturated with warm vertical compaction using free-fill obturation system from the Denjoy company. The same protocol is followed for each and every case. The second case here we are going to discuss was not recognized as Radix entomolaris radiographically, but clinically, as the Radix entomolaris was probably fused to the distal root, so it wasn't so clear in the diagnostic X-ray. But after deroofing the pulp chamber and following the floor map, the orifice of the Radix entomolaris was detected. It had a sharp curvature in the coronal third, glided manually as mentioned in the previous case protocol. The third, and here is the final results. The third case here is a special case. It took a lot of time and many visits. The initial situation was a poorly obturated lower first molar. At the first, when I analyzed the mesial root, it got my attention really, as it was wide, so I thought there might be a middle canal. The distal root had only one poorly obturated canal, so I thought there must be another canal depending on its size, and nothing else reached my mind. After removing the restorations, lots of guttaperca was found in the chamber, so I cleaned the chamber with ultrasonic and started to remove the guttaperca from the canals using rotary files. And as I suspected, the mesial root had 3 canals, but the funny thing that they all joined back at the apical third. The distal root had a canal that was not negotiated by the previous treatment, so by now 5 canals were prepared, 2 distals and 3 mesials, prepared, irrigated, and filled in a single visit. But in less than 1 month, the patient came back complaining a pain on chewing and hot drinks, something that was strange. I thought this case is over, but generally I believe patient complaints should be listened to, as nobody loves us with dentists, so most of the time when the patient complains, they are right and there is a problem. So I took mesially and distally shifted x-rays, and there it was, the Radix Entomolaris. As we can see it right here, by shifting on the shifted x-rays right here. I use 3.5 dental loops as I don't have a microscope, but I couldn't find the orifice no matter what. I brought the light curing device, switched it on the lingual side, on the lingual wall of the tooth distally, and I just couldn't see the orifice. So I asked for a Cbct, and then only I was able to limit my search into a couple of millimeters in the pulp chamber floor. Even then, if it wasn't for the patient pain, when my number 10K file touched the orifice, I seriously think I wouldn't have found it with this sort of magnification. After that, the rest of the treatment was done according to the previously described protocol, and the patient was happy. But I was really happy that it was a success after all. Happy endings. Lessons are taught by one's own experience rather than lectures. The fourth case is also a special case. In this case, the previous dentist treated this tooth, knowing that there was a Radix Entomolaris, and yet failed to negotiate it to the full length, as we can see. I believe that was because he created a ledge. He did not pre-curve the manual file and started going inside the Radix Entomolaris, but it has a sharp curvature in the coronal third, so he made a ledge. But anyway, he discussed this situation with the patient, and a decide was made to obturate it and follow it up. After a couple of months, the patient was in pain again. She went to another dentist, and three files were broken during the retreatment. So he referred it to my office. As a humble endodontist, I don't have a microscope yet, so my first choice when dealing with broken files is to bypass. And it worked for me, as all broken files were bypassed. Let us show the Cbct for this case. As we can see here, the Radix Entomolaris is larger than the previous case, with a curvature in the middle third and in the with curvature in the coronal third and in the apical third. Here is another view at the Cbct, and here we can see it clearly. And the second visit, I bypassed. I'm sorry. I have to say on this picture, my first choice when dealing with broken files, as I don't have a microscope yet, is to bypass the files, and it worked for me in the first case. In the first visit, all broken files were bypassed. In the second visit, I bypassed the ledge, and here we can see the case obturated, just like the protocol mentioned in the earlier cases. The message of this case is for undergraduated or freshly graduated dentists to know when to refer your patient. Assisting case difficulty is a learning subject with its concepts and rules. When you understand it, you can assess your capabilities and try to raise the bar as your experience grows. Thank you very much for watching.